Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medical legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. We're continuing our series on demystifying medical counsel statements today, and today we're looking at exploring professional boundaries in the doctor-patient relationship. That's a good topic. So my name's Dr. Lucy Gibbard. I'm one of the medical legal consultants at Medical Protection, and joining me today we've got Kate Wills, a senior associate at Wood & Kearney, our panel law firm. Hi, Kate.
Hello.
Hi, Kate. And also we have Sam King, and one of the other medical legal consultants at Medical Protection and also a GP. Hi, Sam.
Hey, Lucy.
So the medical counsel statement is from 2018 and it's not exhaustive, but it refers to gifts, bequests, loans, financial transactions and other standard fees. And it also talks about acting as power of attorney for patients, and it touches on the use of social media as well. So we're going to look at all those aspects of that statement today, and let's start with gifts. So in general, I think the most thing I've ever received actually is lemon curd from a patient, but some people get a pair of slippers or a knitted scarf at Christmas time. So in general, Kate, what would you think the council's stance on receiving those kind of gifts from patients is?
So the council has helpfully set out some directives and expectations around gifts in its guidance statement on professional boundaries. The council expects that practitioners will not seek or accept any inducement, gift or hospitality that may affect or be perceived to have the capacity to affect the way they prescribe for, treat or refer patients. Of course, as you have touched on, at times patients or their families might present you with something small and maybe something consumable like muffins or lemon curd as a gesture of appreciation for your care. The council's view on these is that they're generally acceptable, provided that they are token in nature and do not include cash donations. I guess the caution around accepting gifts is that patients should not be led to form the impression that their care is dependent on gifts or donations of any kind. And further, patients' needs and best interests must be the guiding motivator for care decisions, not any personal benefits. So you don't want to sort of muddy the waters when about your motives if you're receiving sort of, nice gifts and whilst providing patient care.
So, Sam, are you aware of any difficulties that our members might have had with this kind of issue with receiving gifts?
Yeah, I am aware of a case a few years ago where a doctor was receiving regular gifts of food, wine and small items from their patients. The patients were from a culture where this is the norm, and it would be offensive if the doctor had refused those gifts. And because they were low-value items, you would think, you don't have to think much about it, but the reality was that it was constant. It was like a constant flow from these particular patients. And I think the issue that the doctor had to think about was whether this impacted their clinical care of the patients. And I think the doctor felt awkward about it because I guess for some of us, if you're getting this constant flow of gifts, whether it obligates you in some way to those patients, and, do you treat them better, or do you feel like you need to give them more attention, spend more time with them, etc., because of the gifts that are coming to you? So I think whilst, the occasional gift we're okay with, it's the constancy of low value gifts that I think sometimes catches us.
It's difficult though, isn't it? Because I have to say the patient that brings me lemon curd is a reasonably regular supply, I have to say. But I have to say from my point of view, I think the motive that it's being given in and also received in is actually important in making that decision that actually I have accepted the lemon curd. So I think you've got to actually look at that as well, because I think if you can still care for that patient objectively, that actually maybe it would be appropriate, do you think? Mm.
And I think if you consider the culture that the patients have come from, if that's their norm, then to them it might seem rude if they didn't provide those gifts to you. I don't know. So I guess you're right. It's about the motive with which the patients have given it. There was another case where there was a slightly higher value item was given, where a very dilapidated mechanical item was offered to a doctor for the doctor to restore, as this was his hobby. And in this case, the considerations were how the rest of the family would view the item being gifted. So you've got this, if it's a dilapidated mechanical item that's been in that patient's family for a very long time, it's probably got some sentimental value to that family. And so the gift, whilst perhaps in a monetary sense wasn't huge, because I'm assuming it's going to cost a lot of money to restore something like that, it's really around the value or the non-financial value that family might hold. And so in that particular case, I think we assisted the doctor and suggested, well, how will the family feel? Or how do they view the item being gifted to the doctor? And would it obligate the doctor in any way to the patient? So those were the considerations, I think.
So I think if in that situation, if you've turned your mind to it and you've thought about it and you've discussed it with your colleagues and you said to the patient, can you just check with your family that they're all right with this? And later there's a concern raised. The medical counsel in that situation, if you've actually shown that you've made a good thought about it and don't think it's going to affect care and the family aren't going to be upset, then in that case, is it acceptable, or is the risk low?
I would think the risk would be low. You've gone to quite an effort to test and interrogate the gift, the motives, the risks around that from the family perspective. If you've bounced it off a colleague, you're being transparent. Obviously, you might want to ask a few more questions. Has that doctor accepted gifts from this patient in the past? If you can sort of assure yourself that there's no obvious exploitation or perception of that, and it seems like everyone will be happy, then I would think the risk would be low. And it's difficult because the guidance statement doesn't say, up to X value, you must say no. It's always a bit grey. And that's why it is so important to have broader discussions and bounce it off other people, not just sort of yourself and the patient.
And I do think that, the culture, but also, I think 50 years ago it would have been much more acceptable, and then it would almost, I think the doctors at Christmas 50 years ago were getting lots and lots and lots of gifts. And I think it is less common now, but that there may be a generation of doctors who feel that it's, it is all right. So I think it's, important to think about it, isn't it? Okay, so let's move on now and look at financial matters. It's difficult to say how often it occurs, but it does happen occasionally that doctors are bequeathed money from a patient in their will. So we're going to consider this one by talking about two scenarios that are based on previous medical protection cases. And the first one is a doctor who was working in private practice and was contacted by the relative of a recently deceased patient advising that there was a gift of $8,000 in the patient's will for the doctor. The doctor was unsure whether she should accept the money and asked MPS to help her make that decision and consider what factors should be considered when she makes a decision about whether or not to accept it. So, Sam, have you thought about what kind of factors would be relevant?
Yes. I mean, $8,000 is not a small sum of money, I think, so I think you do need to really consider this. So I would look at the vulnerability of the patient. Did she have a mental health issues? Was she frail? What was her cognitive function like? So was she competent when she was bequeathing the money? How did the family feel about it? Are the family happy, or, the family going to feel aggrieved that the doctor's been gifted this money? Was the doctor aware that the gift was made prior to the patient's death? Because I think that changes things, being aware of it beforehand. And because if she had been aware of it prior, then you've got to think there were some questions she probably should have asked, at the time. And was there any indication of an appearance of coercion? I mean, I wouldn't expect that the doctor provided any pressure to the patient, but even the appearance of coercion can come across very badly.
Yeah, well, in this particular case, Sam, after speaking to the doctor, it was clear that the patient was actually fully competent and had no mental health issues. And the doctor had been completely unaware of this gift. It was a huge shock to her. The patient had offered her a set of golf clubs previously, as the patient knew that the doctor enjoyed golf, but the doctor had declined those. The family member who contacted the doctor was actually very happy for the doctor to have the gift, as were the family, as they were all aware of how grateful that patient was for the care that was provided by this doctor. And the gift was actually, compared to the patient's actual estate, was only a very small amount compared to the rest of the estate that the family were going to be receiving. So, Kate, what do you think in this situation? Is it okay?
The council's guidance, it doesn't actually address situations where a doctor learns about a gift from a patient after the patient has died. In such a circumstance, there's sort of factors that are present when a patient's alive that are no longer. So things like the gift blurring professional boundaries, causing a risk to patient care, or influencing imminent care decisions. They're obviously no longer factors to consider. With that said, the gift could still prompt some questions or concern about the nature of the relationship between the doctor and the patient when the patient was alive. And so in a case like the one that you've just described, Lucy, the risks would appear, in my view, to be at the lower end of the spectrum. Of course, there is inherent imbalance in the doctor-patient relationship, but it did not appear that the patient was particularly vulnerable. She had capacity. It's significant, I think, that the doctor declined offers of gifts while the patient was alive. So she said no to the golf clubs, and that sort of leans against exploitation. Where the doctor was unaware of the gift, it could be assumed that she didn't exert pressure on the patient to provide it. And also, the fact that the family was comfortable that the gift was appropriate in the context of the care is quite telling. And it seems that it's proportionate to the estate too. The gift is potentially not, in fact, while $8,000 seems like a lot of money, potentially in this circumstance with a large estate, it may not, in fact, be too significant. In terms of advice in a situation like this, I think the doctor did a great, the exact right thing in engaging with the patient's family as she did, and also checking in with the MPS. So those are two sensible steps you can take. But having done that, I would suggest in this situation, she probably could accept the gift.
Interesting. That's good. So it's not really about the amount of the gift. It's actually all that other stuff around it that's almost more important.
Proportionality is important,
Because $500 from somebody else might be even significant, whereas $8,000 from this particular person was considered appropriate. Interesting. So looking at another case, again based on a case but not the exact facts, this was a patient who was known to the doctor on a social level. They weren't close friends, but the doctor had treated the patient over many years. And when the patient died, the doctor had been bequeathed $700,000 by the patient, which is a whole different level of gift. So, Kate, what information would you ask of a member who rang up and asked, can I accept a $700,000 gift?
Yeah, so I do agree. We're in another ball game here, $700,000. It's a lot of money. So that makes it really important to interrogate the circumstances around this bequest in a lot of detail. I guess broadly at the outset, I'd want to really understand the doctor's relationship with the patient, the length, the intensity, what it involved, what health issues were addressed. Was the patient treated in the same way that other patients with the same conditions would be by this doctor? I'd definitely want to understand the patient's health at the point the gift was bequeathed. And those are those important questions around whether they had capacity at that time. Also, you might want to understand, had they just been given the news that they were in remission? Some great news as part of the context of their care that might have led them to make this generous decision that potentially, might not have been wise, and maybe they wouldn't have made it if they were in a different context of their care. I would want to find out information about potential motives. Was the doctor aware that the patient held the doctor in particularly high regard? Do the executors of the estate or does the patient's family have any information about why the gift might have been left? Who are the other benefactors? That could shed further light on motives. From the doctor, I'd definitely want to know if the patient had given or tried to give the doctor gifts in the past while they were alive. I'd want to know if discussions were ever had between them about the patient's estate and their plans once they passed on. Was the doctor aware of the gift or aware of a potential for a gift? And I'd also want to know if the doctor knew if the patient was well off. Those sort of latter points might allow you to understand motives on the doctor's part for potentially, fostering a bit of a special relationship or with a patient like this. You just really want to understand those sorts of risks. Lastly, I definitely would want to try and get the family's view about the gift, and again, understand how significant it is in proportion to the estate as a whole. Those are sort of some definite initial sort of bits of information I'd be seeking.
Because we are talking about professional boundaries here, aren't we? And generally, the doctor-patient relationship is not one whereby the patient would generally be expected or to be giving the doctor any kind of request, would it? So it is already outside the normal boundaries of what is expected in that relationship. So I think that I can understand why you would want to scrutinise that carefully. So Kate, once you've got all that information, so we've heard from the family, we've understood about competence, we've looked at the relationship and any previous gifts, then what do we do? Can we just say yes?
Oh, I'd be a bit hesitant to do that with a gift of this size. I would definitely suggest engaging with the MPS or another lawyer to obtain an objective view on whether all of that information you've collected about the circumstances lend it to be ethically permissible to accept this bequest of $700,000. If the advice received from the lawyer or the MPS was that, hey, actually, it could be okay in all of these circumstances that you've gathered, I would still suggest that nonetheless the council be notified of the gift and tell them about the gift, tell them about the advice you've received from a lawyer or the MPS, and let them know that having regard to that advice, your intention at that stage is to keep it. And I would invite the council to communicate any concerns about that. I just think it would be prudent to receive a steer on whether the council had any worries at this sort of early stage, so the doctor can consider any professional risks were they to accept the gift and were the council to take action in response. Definitely while you're seeking that third-party advice and potentially engaging with the council, don't spend the money, protect it, and lock it away until the council's position is understood and until you feel comfortable that taking that professional risk and keeping it.
So if the council said no, we don't think it's appropriate for you to accept this gift, do they have any legal ability to do that, or could the doctor say, "Well, actually, I'm going to anyway"? And then what? And then what would happen? There'll be a professional conduct committee investigation.
Yep, and we'd put all the good advice we'd got from lawyers and the MPS on how the circumstances lend it to be appropriate, and you just have to have that argument in that context. But it's good to, it's good for the practitioner to be alert to that process maybe taking place down the track, because gifts like this of this size, it may have an influence on how that doctor might be perceived in his community or amongst his colleagues. So those sorts of professional and reputational considerations, the doctor might want to think about and be alert to before proceeding to accept the gift.
Well, interestingly, in both these cases, the the doctor wasn't aware of the bequest, but that in this particular case, the council considered it and didn't object, and the doctor kept the money. So lucky them. Moving on again, what if the patient spoke to you about it while they were alive? What if the patient said, "I'm going to leave you money in my will"? What should the doctor have said at that point if they were aware of it beforehand?
Well, the medical council in their statement say, do not encourage patients to give, lend or bequeath money or gifts that will benefit you. As with a gift, the best option is to refuse a bequest with a polite explanation or request that it be reassigned, and document any actions you take in response to the bequest. So I think council don't put a blanket no. They say you must not. They don't say that. But they say the best option is to refuse. So I think you need to weigh up the pros and cons, the risk. I guess you have to ask all of the same questions. Is this going to influence me? Why is the patient giving it to me? Are they vulnerable? How do the family feel about it? And all of those sorts of questions, and then make your decision. I think if there is a complaint, you do need to justify why you've accepted the bequest.
Absolutely. Okay, well, moving on now, we're going to talk about loans in the current high interest environment. Is it ever okay to take a loan from your patient? We're going to consider a case here where a doctor was found guilty of a professional misconduct when he accepted a loan from an elderly patient who was terminally ill. So, Kate, can you tell us about that case and why he was found guilty on that charge?
Yes, sure thing. So this case involved a GP, and he'd cared for an 80-year-old patient intermittently for only about 2 months before the patient was diagnosed with terminal cancer. 8 days after the diagnosis, the patient communicated a wish to gift the doctor $150,000. The doctor gave evidence that the intention underlying the gift was to assist the health needs of the people in the local community. The doctor swiftly opened a bank account into which the funds were to be accepted, and the day after the offer, he prepared a statement for the patient to sign that confirmed the gift. The statement also confirmed that the beneficiaries were to be members of the local community, and that the GP was to be the trustee with unrestrained powers to administer those funds. The document was then signed by the doctor and the patient. There were no witnesses, though, and the doctor did not disclose the fact of the gift or seek any advice around any ethical or professional issues arising. He made no record of the discussion with the patient, and he did not document the gift in the medical notes. The patient's son discovered the payment to the doctor and was quite concerned. His father had not mentioned it to him at all while he was alive. So this came to the disciplinary tribunal after a conduct investigation. And the tribunal did find that at the relevant time, the patient did have decision-making capacity. They found there was no evidence of undue influence, and it was accepted that the payment was at the instigation of the patient rather than the doctor. They also found that the patient didn't want the doctor's clinic to be involved, and the patient didn't want any reference to the donation being made in the notes. Against this, there were factors that imposed significant responsibilities on the doctor in respect of the transaction, and the tribunal listed these out. They considered that the patient was very vulnerable, where he was elderly and in the last weeks of life. They noted that the quantum of the transaction was significant, and that's proportionate to the patient's financial situation as well. The relationship between them was very brief. The doctor didn't actually know the patient very well at all. The implementation of the decision was very swift. Money's in the account the next day, statement signed, no one talks, that end of story, within a couple of days. The doctor admitted he was aware at the time of the potential for ethical issues, and that really put the tribunal on high alert that he should have taken advice from a senior colleague or the practice manager, and that they maintained this view even though the patient had said he wanted everything to remain confidential. The tribunal rightly pointed out that taking that advice didn't need to come with identifying the patient. That could have been sought anonymously. And as you said, Lucy, the ultimate outcome was that the doctor was found guilty of professional misconduct on the basis that his actions amounted to malpractice, which is defined as being unethical conduct, and also on the grounds that it brought discredit to the medical profession. The tribunal considered that there was a clear ethical issue that required the doctor to refuse to facilitate the transaction and accept the funds. Or, at the very least, he needed to first obtain advice. The tribunal said that had the transaction been appropriate, the transaction itself and discussions around it should have definitely have been recorded as with reference to that signed document specifically.
Okay, so that's interesting, isn't it?
Do you think that had the doctor done things differently, then he wouldn't have gone through all of this through the tribunal, and that it would have been okay?
It's hard to be definitive because it's speculative, and we don't know what other information would have come forward. But, had someone sat down with the patient and the doctor and really talked to the patient about, is this what you want? Why do you want it? Because the motives were good. It was to benefit the local community, and so, had advice been sought around that and had objective third parties been assured that this is actually what the patient does want, had people checked the terms of the signed statement, I think you could have actually modified it to make it a bit more safe and appropriate. I think the doctor vested a lot of power in himself and been able to administer the funds as he wished, but you could have put safeguards on that and talked to the patient about what specifically are you thinking with this money, and being quite specific in that written statement that was then witnessed and signed. So it's impossible to say it would have been fine if you'd done these things, but I think there were things that could have been done to at least get a better picture and more safely construct this agreement in a way that would be more defensible now. I think that the big bugbear, clearly from the tribunal's perspective, was the lack of transparency and openness around all this and the speed at which it happened. There wasn't a rush. He was terminally ill, but, it didn't need to happen in 2 days. So, yeah, it could have been fine had more steps been taken.
It was interesting that the facts came out in the case where the patient apparently didn't want anything made of it in the notes, so nothing was to be noted in the clinical file, which is quite an unusual request, really, when you think about that.
I thought so too. On reading the decision, the patient appeared to be quite a humble man who lived a relatively quiet life, and he did love his community and engage, he had neighbours come over and care for him and visit him and that sort of thing. So I kind of thought potentially someone like that, who's just humble and wants to give back but doesn't want a big show about it, that might be an explanation. But I thought, it's interesting. Obviously the tribunal they accepted that request for confidentiality did come from the patient. So there's no suggestion that it was the doctor saying, don't tell anyone. So there must have been enough information for the tribunal to be assured that that is actually what the patient wanted.
Very interesting case.
Yeah, so that we've talked about bequests. What about borrowing money from a patient? Do you reckon there's any situations where it would be professionally appropriate for a doctor to borrow money from a patient?
I struggle to think of a clear, when I think of that, I think of a lot of risk. I know that the council expects practitioners will not encourage patients to lend them money. So that's sort of the starting point. It could create, borrowing from a patient could create a risk or a perception of risk to providing objective care. And a couple of questions that come to my mind is, would the doctor behave as they would with all other patients if they felt beholden in some way having received this loan? Another sort of worry is, could the patient take advantage of being in a position of power over the doctor,
Yeah.
you sort of want to avoid those situations.
I guess if you're in a small community, if you work rurally, I expect it's not uncommon where, your bank manager, for example, is your patient as well.
Yeah, I think if that's a professional interaction, though, I think you're allowed to get money from your bank manager, hopefully. But the other thing is whether or not, it's actually down the pub and someone shouts you the round of drinks and you've forgotten your wallet and you owe them from that. It's all grey, isn't it?
It's very contextual, yeah.
But I think that really it's that whole thing about, is it professional? Is it going to affect the patient care? Would it be would it be perceived by others?
Exactly. And if you were to sort of arrange this transaction of a loan or what have you, you'd want to, probably the advice is don't, but if you did, you'd want to put in place those safeguards that the tribunal sort of highlighted around clear documentation, witnessed, take advice. You want to be able to make that a defensible
It's
exchange.
so hard to think of any circumstance where it would be appropriate,
Yes.
though, because it would be unusual for a patient to offer a doctor a loan unless they knew the doctor needed one, and as soon as the doctor asks, then actually that's outside the statement, isn't it? So, yeah, I struggle to see.
I expect if you're going to if you need to ask someone for a loan, they're the only person perhaps available, I don't know, then they should probably not be your patient anymore.
Yeah.
You should probably end that therapeutic relationship.
Yeah.
Yeah, I wonder what the medical council would think about that, ending the therapeutic relationship so you can get a loan from the person. Not sure they'd be keen on that either, really.
No.
But anyway, moving on. So look, probably a more common situation, and definitely one that I've had on our advice line, is when a patient asks their doctor to be their EPOA, or where the family asks the doctor to be a welfare guardian. And obviously that's a situation where the patient trusts the doctor and they feel that they would be in a good position to make health decisions for them. But what do you think about that, Kate? Do you think that would be reasonable for a doctor to become an EPOA for a patient?
I know that the council's position is that, in most instances, acting for patients through representation agreements or by accepting responsibilities under an EPOA, the council's view is that that is unwise. That's their terminology. And I guess the basis for this is that the practitioner could be perceived as having exerted undue influence on these patients to enable them to get to that position. So, yes, I would think it would be unwise.
I also think the problem would be that because often as a GP you're seeking consent of the EPOA to perform a procedure or to consent to a treatment, and if you're the EPOA, that has clearly got to be a conflict, hasn't it? What do you think, Sam?
I think so. I don't think you can continue as their treating clinician if you're their EPOA. EPOA.
Yeah, I think the doctor in that position where they're asked, will you be an EPOA, will you be a welfare guardian, I think the answer should be no. I think we'll be reasonably clear on that one, shall we?
Reasonably clear. I have spoken to a member about that, and the doctor was extremely uncomfortable and didn't want to do it, precisely for those reasons. And it was just the fact that the poor patient didn't have anyone else who was responsible enough to take that role. So it put the doctor in a very difficult position.
Yeah. I can see why a patient would think the doctor would be in a very good position to make those health decisions for them. There may be a very long relationship there, 20 years of trust. And who else? I can see why that happened. From the patient's point of view, it's a perfect person. But actually, from the doctor's point of view, I think we can agree that it's not perfect. So lastly, let's just touch on social media, which I have to say is probably getting to be more and more of an issue when we look at the calls we're getting on our advice line. And the question of whether or not it's all right for a patient to be friends on Facebook. If it's initiated by a patient and there's no romantic motivation, let's say you're in the same Facebook group because of a community Facebook group or because of a love of your cats or dogs, and the patient wants to be friends with you because they recognise you, and I'm sure most of us have had friends requests from patients who recognise you. Is that okay?
My personal view is generally no. I mean, most of us don't give our cell phone number out to our patients or our personal email because it means that patients can contact us. And being Facebook friends, is it a real friendship for a start? I don't think it is. But if you think about it, they get access to your personal life that they wouldn't have any other way. And so in general, I would say no.
Yeah, I think it's a blurring of those boundaries, isn't it? I think it's very clear, and I think the Medical Council are pretty clear that you should keep your personal and professional life separate as far as possible. So I think, in fact, the statement says that you should also avoid relationships with former patients as well as your current patients. So I think they're reasonably clear that you should be maintaining those professional boundaries in the use of social media.
It's sort of like another forum too, where potentially a doctor could be asked medical questions, and that would be really inappropriate over social media, because then what happens, it's outside of the medical record, it's remote, it just creates risk.
Yeah, I think it does. The Medical Council statement also actually talks about text messaging, which obviously can be an appropriate form of professional communication. Most of our practice management systems now allow us to send out reminders to patients for their appointments, and I think we can all agree that that form of text is appropriate. It's clinical. It's in the clinical context. It isn't a blurring of boundaries, but we really do need to think about those professional boundaries when we are text messaging patients, so that patients don't misinterpret their relationship with their doctor to maybe be more personal or more friendship based than it actually is. And so that, I think when you're using the PMS to text, it's a much safer system because it's all recorded in the patient's notes. If you're actually at home at the weekend and texting your patient from your own personal cell phone, I don't know what you think, Sam, but I think that definitely blurs. It comes to the blur. There may be some emergency situations where you feel you have to do that, but I think.
Yeah, I agree. I don't think it's appropriate, although I'm aware of some clinicians who do use text on their personal cell phone in a therapeutic way. They're communicating with patients. I think that if you're going to do that, you do need to make sure it makes its way into the clinical notes. Don't just leave it on your phone, because I think that can come across as being blurring of a boundary. But if it's a definitive clinical issue and you put it in the clinical notes, then I think people can be clear. No, this was purely a professional relationship.
Yeah, and I have had assisted doctors where there have been criticism of the fact that they messaged the patient on their personal cell phone to arrange to meet them, and that was considered inappropriate use of text messaging. And as you say, putting it in the notes is really important, and often those things don't get transmitted onto the notes. I think there are some clinical services, though, where you've got a work cell phone, and that's actually part of the therapeutic touching base with the patient. So I think there are situations where texting from a cell phone is appropriate, but I think it should be clearly work-based. So in a fictitious case we're going to think about now is a junior doctor in a relationship with a married woman, and the junior doctor posted about this relationship on social media. Unfortunately, the woman's husband found out and contacted the junior doctor, and it all got very messy very quickly, as the doctor had actually posted some very personal details online. So this is a doctor in a relationship with a married woman. I don't think the married woman was actually a patient at all. So actually, is this anything to do with the doctor's professional practice? Do you think the council has got any jurisdiction? Are doctors banned from having relationships with married people?
It would definitely depend on the nature of the post in question. It certainly would not be appropriate for the council to become involved by virtue of the relationship alone. They're not sort of the moral police around that. But if the public online communications were considered to be unprofessional and to potentially discredit the medical profession, that could fall within the council's remit. And it could be treated as a conduct matter. To treat it as a conduct matter, it would typically require the person making the post to be identifiable as a doctor, because that's sort of necessary to bring discredit to the profession generally. But with that said, even an anonymous post or where there's no link to being a health practitioner could actually result in the council taking action on the basis of competence concerns. We've seen that before. That sort of situation could arise where the comments were perceived to contain personal beliefs that could undermine or jeopardise relationships with patients or certain patient groups. For example, comments that might identify a need to undertake training on cultural safety or unconscious bias, those sorts of things.
Yeah, I think I've had several cases now where doctors have posted things on Facebook groups, not used their own name, thought that it was a private group, and then have posted comments not to do with necessarily anything to do with their practice of medicine, posted comments that have offended people who have become aware that that person is a doctor, and has then reported them to the medical council. And there was a case several years ago where that went to a conduct committee, and it was very distressing for the doctor and totally from left field from their point of view, that they had thought they were posting on a private group and they weren't using their own name, but actually still they were identified and reported. So
it interests me that our personal lives can come under the jurisdiction of the medical council, and to be honest, I question that.
It's a bit shocking, isn't it?
It is a little bit shocking.
It is amazing, should you be told when you're in medical school that actually your right to freedom of speech can be more limited than, the person next door. I was about to say law school, but no, we're also regulated,
Yeah.
the person in the tradie school, because by virtue of our professional registration, we have a right to freedom of speech that's protected under the Bill of Rights Act. However, it is that can be limited if that freedom of speech is deemed to sort of, it can be limited by our professional responsibilities.
And I think that's deeply shocking to many doctors, that they have no idea that actually I wasn't at work, it wasn't about my work, how can the medical council have anything to say about that? I think it's very shocking to doctors that's
it is,
the case.
And to be honest, I'm not sure I agree with it. I mean, this fictitious case that you talked about, I have a case which was obviously not exactly the same, but along similar lines, and it was interesting how council wanted to be involved in it, and yet it's entirely about a private relationship that was had. And you wonder how on earth, what freedom do we have as doctors if council can get involved in those sorts of things?
I think that's a very good point, Sam. But I think the reality is that it's, as I say, I've assisted in a case in the past on that as well. So I think that it is the reality that we are with.
Yeah, and I think a lot of it comes from that professional obligation not to discredit the profession. So the council's mandate is to consider what the public may perceive by this conduct, and whether, if it's allowed to sit there without action, the reputation of the medical profession generally may be impacted. I expect that is probably where they come from with some of it. But yeah, certainly feels like they have a broad reach into private lives of doctors.
Yeah, they do. So thank you both very much, Sam and Kate. So look, just bringing this all together, what are our take-home messages here about professional boundaries? So first of all, I think we can say that financial dealings of any kind need to be completely transparent, well documented and open. And if there's any doubt as to whether it would be considered a boundary issue, you are best to take advice, and you really want to avoid any hint or even an appearance of coercion or undue influence. Be aware of your online presence. It's very easy for people to take your posts and use them against you. And that's, as I say, that's something that many doctors aren't aware of. So thank you for listening to this podcast. I hope it's been helpful. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcast, please subscribe and leave a review. If you would like a podcast on a specific topic or would like to leave comments on this one, please email us on nzpodcasts@medicalprotection.org. So thank you very much, Kate. Thanks, Sam. And we'll see you next time.
Thanks, Lucy.
Thanks, Lucy.